We used to give Propulsid to premature infants for reflux. It wasn't approved for that. It had never been tested in premature infants, but it was being used everywhere in NICUs across the country. And then we started finding babies in the NICU with prolonged QT intervals. We started finding unexplained deaths, and we started asking, what do these patients have in common? The answer was Propulsid. Propulsid was approved in 1993 for a specific limited use, nighttime heartburn in adults who hadn't responded to other treatments. Its mechanism was elegant. It stimulated the gut's own nerve network to move food through more efficiently, reducing the reflux of acid into the esophagus. But Propulsid also interacted with cardiac ion channels. Specifically, it blocked the Hg potassium channel, which plays a critical role in regulating the heart's electrical repolarization. Block that channel, and the QT interval, the measure of how long it takes the heart to reset between beats, becomes prolonged. A prolonged QT interval is the precursor to a potentially fatal arrhythmia called torsade de pointe, which can become ventricular fibrillation, which can become sudden death. The off-label use of Propulsid in infants became one of the most troubling dimensions of this story. Infant reflux is common, distressing for parents, and difficult to treat. Neonatologists and pediatricians across the country began using Propulsid in babies, including premature infants in the NICU, despite the drug having been studied and approved only in adults. Premature infants have immature cardiac conduction systems and immature liver enzyme activity, meaning they metabolize drugs more slowly and their hearts are more vulnerable to QT prolongation. They were the worst possible population to give a QT prolonging drug to. Several died. Our daughter was born 6 weeks early. She had reflux and wasn't feeding well. The NICU gave her Propulsid. She was 8 weeks old when she had a cardiac event in the middle of the night. She survived, but she had damage. Her cardiologist told us years later that the Propulsid had almost certainly caused it. She had been in the care of some of the best neonatologists in the country. Nobody had warned them. By the time Johnson & Johnson withdrew Propulsid in March 2000, the drug had been prescribed to approximately 30 million Americans. The FDA had received reports of 341 serious cardiac arrhythmias and over 80 deaths. A black box warning had been added in 1998, and a revised prescribing program was implemented, but adverse events continued. Johnson & Johnson maintained that Propulsid was safe and effective, but in the real world, where antifungal medications or grapefruit juice elevated drug levels, the drug's safety profile failed to hold. 7 drugs, 7 withdrawals, hundreds of thousands of patients harmed, tens of thousands dead. Each case is different, each failure has its own character. And yet they share something. They share the gap. The gap between what we know about a drug when we approve it and what we only discover when millions of people take it. That gap may be irreducible. Medicine advances by testing, and testing always carries risk. But the cases in this series were not failures of science. They were failures of honesty, of systems that muffled danger signals, of financial incentives that outweighed safety incentives, of regulatory cultures where bad news traveled slowly. Drugs don't become mass phenomena overnight. They move through reps, detailers, dinners, and conferences. Each of those nodes is a place where a safety signal could be amplified or suppressed. The patients in these stories are not cautionary abstractions. They had names. They had families. They had doctors who were trying to help them. The question of drug safety is not a bureaucratic problem. It is a human one, and it is not finished.